For the pregnant women, it's 3%, and the people above 60, there's more of them. I think the jump is up to 7%. So like there's a lot of mentions in the media for the ministries saying that all these people are supposed to get health care for free. Yes, there's actually a change, more accessing free care, but it's not 100%. People are still having to pay for the health care services. And also, we also wanted to engage the perception of the citizens regarding PF3, because we all know in Tanzania, I don't know about other countries, if you get an injury from an accident or a fight, you're actually supposed to get a PF3 before getting treatment. So we wanted to ask the citizens, how do they feel about it? Do they think like they should get PF3 first and then get treatment, or they should get treatment and then the PF3 can come back later? Because depending on the gravity of the injuries, some of the injuries are life-threatening. So if you wait for a PF3, a person can actually lose a life. So when we asked this question, people in 2016, 79% were in agreement that patients should be attended to before getting PF3, and it jumped up to 84% in 2017. So it shows actually people in favor of getting the treatment first before getting the PF3. And then this was only based on perception, but when you actually ask the people who actually experienced an injury, so 16% of the citizens reported they experienced an injury due to an accident or a fight, and 58% who went to the health facility were asked for a PF3, and about 32% said that it took more than an hour to actually get the form, and actually they have to take it back to the health facility to actually access health care. So it shows that there's this form which is required, and to get it, it actually takes a lot of time. So like depending on how serious the accident is, it can cause a person to lose a life and they won't be able to access health care. And then we know for the Ministry of Health, there's another umbrella of the social welfare, which is supposed to help citizens with other factors which do not need medical attention, maybe psychological advice on various issues, especially for the vulnerable groups, which are the children, mostly the orphans, the women, and the elderly people. So we wanted to engage the people's awareness of this particular post in their, I guess, in their area. So when we ask these people, are you aware of a public servant known as a social welfare officer, only 17% are actually aware of the person of that role and their responsibilities, while 73% are not aware of the social welfare officer post, and the 11% are aware of the role, but they don't know their responsibilities. So the 17% who are actually aware of the role and the responsibilities say that their main responsibility is to make sure women get their rights. There's also to make sure children get their rights, they protect vulnerable children such as orphans, protect the elderly, and help the citizens know their rights. And also we also asked these people if they have a social welfare officer in their district. So 20% reported having a social welfare officer, and then among the 20%, only 1% actually sought a service from the social welfare officer, and they were mainly to do with protecting the women's rights. Were too expensive, which means people cannot afford. And also having health insurance is a guarantee. Even if you don't have money in your pocket, you can actually access the service and be treated based on your illness. So when we ask the citizens, do you personally have health or medical insurance? In 2017, it shows 27% have medical health insurance. If you look across the years, it went from 21 to 24. Looking at this trend for Tanzania to actually achieve universal health care for everyone, whereby it will be at 100%, it will be in the next 40 years. So in 2055, that's when we can actually have everyone in Tanzania having health insurance, which will guarantee for them to get health care even if they don't have money in their pockets. So, and then when you ask them what kind of insurance do you have, that's the 27%. 13% have the CHF, which is the Community Health Fund, and then 8% have NHIF, 2% have strategies, and 1% have NSSF, and 73% have no insurance. So 73% is such a huge number to consider that people are sick every day and you can't know when you are going to be sick or not. So having health insurance, it can actually guarantee them not to spend so much money. So that's about it on our data. We can see there is improvement in the health sector, especially if you look at the numbers are representative of the nation, but these ones are representative on the national level. So there are improvement in the health sector where there are, I guess the doctors are present, even they are not actually all of them. The waiting time has decreased, but the challenges are still there, which means there is no medicine and also enough beds for everyone. So we should celebrate for whatever has been achieved in the meantime, but there's more challenges to be tackled to make sure, like when people access the health services, they get the quality care that they deserve. So thank you.
Great. Just maybe, last time we were lucky enough to have the Deputy Minister of Health come when we presented these findings, strategies by which I think that the ministry is pursuing in order to kind of increase access to health services. So what you can see here is, yes, it's 13% of the population, it's the biggest insurance provider, but as the previous slide shows, that growth is not very fast. So if that's our kind of major prong for making sure people can access health services, we may be going too slow. And yet at the same time, we are seeing a jump in people. Because our last launch was about security issues, and we had some engagement with the police around that, as well as last year we had these findings where 79% of people support the idea of people being treated before showing the form. It doesn't mean that you don't have to get the form at all, it just means that you get it as you're being treated, so your kind of life is not being endangered. And what's interesting is for this and the question of free treatment to those certain groups, both the kind of Deputy Minister of Health and the Minister of Health last year made quite a lot of announcements sort of warning health workers who were charging exempt groups, saying very clearly that health facilities should not wait for PF3s in order for people to be treated, especially when they're in really dire situations, yet we're still finding that these things are happening. So it's a kind of an interesting sort of divide that you have there, where the ministers and the high level kind of officials are making these announcements and saying, we should actually be following policy, which is that you don't need this form, yet in practice 58% of people, that's a chunk, over half of people who are going to seek this kind of treatment are being asked to wait. So there's clearly a bit of a disconnect there between the people who are making the policies and the pronouncements and what's actually going on the ground. So now what I'd like to do is open it up to some kind of clarification questions, if there are any, and then I'll push you in groups for a little discussion. I have some questions to guide you in that. So I know, sir, you had a question, so I'll give you the floor
Thank
first.
you for the very clear presentation. I just have a couple questions. The first one is on statistical significance and the rigor that was done. I know it's a sample of 1,800 persons polled. I mean, are they polled at the national level? Is it representative of the nation, or is it more focused in urban versus rural? And in terms of the analysis of the data, a 4 or 5% difference, is it statistically significant or not? Just want to, because we're making a fair amount of conclusions or coming to certain conclusions, just want to make sure that it's within a certain confidence. Another point was around, you showed that there's an improvement in waiting time. Again, within the level of confidence. But then we see that there are absent doctors, there's lack of medicines. I mean, how do you really reconcile that there are less human resources, and there are more people coming, as you said, but then they're waiting less? I mean, I think there's a bit of a disconnect there. So if you're able to perhaps shed some light on that. And one last one is traditional healers. It's not a big thing in Tanzania, yes or no? And it wasn't part of where people are seeking care. So if you could touch on that. Thank you.
Do you want to do the methodology?
Yeah. So our sample is representative at national level. So it's urban-rural representation 36-64. And then the way we did the random sampling, the other demographic criteria, which are age, gender, education level, they all fall within the NBS standards. And then the other thing you asked about the confidence interval, Melania, can you answer that?
So for Sauti, what we do is we do the first level analysis. option of looking to the data, and you can run those particular significance and the T-square or coefficient which you want to do. So for this, usually we just do the first level analysis of any improvement we've seen. So we cancel this activity like, you know, this has increased this significant, but you have that option as a user to do so. Or if you saw one, you can actually run those significant differences. For that, you understand?
Yeah.
Okay, so
And for the second question about the waiting time and the volume of patients, so for us as Twaweza, we put the benchmark at 1 hour. But for someone else, they want to be like as soon as they get there to be treated. So yes, there is a lot of people going to the government health facilities and they're absent doctors, but the actual doctors who are there are attending to the patients within that particular amount of time. You get what I'm saying? It can be like confusing, like there are less doctors, more patients, and the waiting time is less. But in other places, it could be as soon as I get there, I should be treated in like 0 minutes. So for us as Twaweza, we put a benchmark at 1 hour. Someone else could do 15 minutes, others 5 minutes, or another person can do 1 minute.
And you say doctor, but you don't really mean a doctor. You mean a human resource, like could be a nurse, could be a clinical
Yes,
officer.
especially if you go to the rural areas,
Yeah.
even a nurse for them is a doctor.
Yeah. So
Yeah.
just to,
Maybe just to add, sorry, really quickly, is we do normally have for significance, you know, just as an eyeball, generally plus or minus 2% is our
Yeah.
average sort of
Yeah.
confidence interval. And the sample is definitely nationally representative for Tanzania, but it doesn't include Zanzibar. That doesn't actually mean it's not representative, but we like to talk about Zanzibar separately because
Yeah.
often when we were able to collect data from there through partners, you know, the findings can be quite different. So we, you know, want to make that very clear. And on the contradictions, I mean, you know, I think one thing you can say that appears to be happening from this data is that things are getting better at a faster rate than this, actually, because you're having more people access the facilities, as you noted, yet the waiting time, you know, more and more people are being treated within an hour. So it's kind of, you know, massive, perhaps a greater improvement than there is. And the question of absent doctors, I mean, from last year, it did, you know, the issue got worse again, but there was a really significant drop between 2015 and 2016. You know, you were seeing something like from 43 to 18. And so I think there's this sense, you know, what Nellen was kind of referring to as the monkey effect. You know, there's a bit of a sense in public service now that, you know, people are keeping an eye on what I'm doing, and so if I'm in, you know, sometimes it could be that doctors were present, but they were not treating people fast, or, you know, there's this sort of like on the job but not really on the job. And I think some of those, that would be an interpretive thing. It's obviously not necessarily verified by the data, but some of those issues are being addressed as well by people feeling more kind of under pressure to perform. And so that might be why you encounter these kind of contradictions. But also we always find in Sub-Saharan Nigeria that, you know, when it's talking about people's remembrances, their experiences, their opinions, you do get contradictions. And that's part of the kind of human element of, you know, polling people.
can I ask just a follow-up quick? In terms of quality, I know the power of this kind of approach might not be able to get to the quality of care and the outcomes of the care, but do you have any experience looking at improvements in quality of care through similar polls?
No,
Because I mean, you could provide more services, but if the quality isn't there, then you're just providing more services of poor quality.
And I think we're careful about.
We had a question previously on bicycle. Then it says it's subjective. I mean, it's a quality rate because we're not a quality rate. But you may say yes or no. You have to quality task we had data showing that this has improved diagnosis, one has changed. And I know the data we had the facility audit where it actually checked the diagnosis vis-a-vis that is actually diagnosis we supposed to be given. So we usually get, we usually reserve aspect of quality, even education when we do that, because someone will always tell you how it has improved. We could share that data, but normally it's a subjective thing, which it depends on that particular person, how he perceives what actually quality is.
But that's also important.
Yeah.
If I go to a facility and I feel that I've been, I've received what I wanted or I felt that I needed, I mean, that's an important
Right, or it could just be that your expectations are so low that you know. I mean, there is really good data from the SDI on, I'm sure you are familiar with it, testing the kind of diagnostic capability of doctors, the type of services from a bit more of a, less subjective standpoint, perhaps. I mean, we're quite careful with Sauti with the questions we ask, as Melanie is saying, to make sure that it's things that really can be informed by citizens' feelings, views, experiences, rather than trying to make some sort of larger pronouncement about the quality of healthcare. Sorry, so you've had your hand for a while.
Oh, it wasn't mentioned as top of mind.
That in terms of how you define your time frame for 1 hour. Because from personal experience, there's multiple wait times when you go to a public institution. There's the time to get your form or you get your name heard. Then there's another time to see the doctor. Then there is time, if you have tests to get done, there's time to have to go and take those tests. I was wondering what you use to define the 1 hour. And based on your findings with absent doctors and personal experience, I find that the time to wait to see the doctor or to get your diagnosis is actually longer than the time you get attended to get your forms done. And I was wondering if you considered that when you're defining time.
Should we take 2 or 3 and then, because I'm seeing lots of hands. All right, sorry, at the back, then here.
There's another one back there.
Let me do 3, and then I'm seeing you all. I see you, and there was somebody else at the back. Please.
Okay, well, my name is statistical data upon the insurance. So what I've noticed yet from my personal experience is that the only difference between the people who is holding an insurance and who has not is just who this has, this hasn't. But looking on the actual service that is being delivered from these institutions is actually the same, because when a person goes to the hospital, is expected to receive a well treatment when in terms of medicine, care, and all that. But I'm holding a certificate also. A patient eventually misses, and they are just ordered to go to the pharmacy to buy for yourself. So, based on your research, what conclusion have you come up to make sure that people are getting medicines at the end of the treatment, because that's every patient expects from the hospital. So it's really disappointing when you go there, you have an insurance, then you get treated, just wait, then you're told to go and buy medicine.
Shall we take these 3 and then?
And there was another lady at the back.
There's 2. Then there's 2 more. I thought we'd do another round.
Okay.
Nellen, we can do another round.
Okay.
Yeah, and sorry, just to say, mnaweza mkauliza kwa Kiswahili pia, hatuna shida, tumeanza Kiingereza. So do you want to?
Yeah. So the first one was time to be attended. It was time to see the doctor. So it didn't include like going for the lab, getting the lab test back, and actually getting like the which medication you need to use and all of that stuff. So the 1 hour was time to actually get registered and see the doctor. And also the other question was lugha ya mahojiano. Tunawahoji kwa Kiswahili na tuwauliza afisa ustawi wa jamii. Kwa sababu sisi hatukujua kwamba kuna jina la baba Huruma, mama Huruma, kwa hiyo hatukutumia hilo neno. Yeah. Afisa, yeah. And then your question on insurance and medication. Yes, insurance can help you to get access to healthcare, but there is no guarantee you actually get medication. So for us, we just wanted to measure whether people have insurance, and then for them to get medication or not, it's a challenge which was mentioned. So we can't guarantee, like, just because we know people have insurance, we have to make sure they get medication. For us, it's just to gauge their opinion and also see what challenges they're facing and whether they have insurance, which is very important for people to get healthcare, considering how expensive it is.
And because it's such a kind of pillar of the Ministry of Health to push, especially ICHF now it's called, we wanted to kind of see how far is this access improving. So you're very right that it's not a guarantee of quality service, or it's not a guarantee that you get, the medicines and equipment you need, but it's at least some way of alleviating what can be a large shock to particularly families living in poverty of healthcare expenses. That's what insurance does. It just spreads payments. I mean, it doesn't change the fundamental systems, I don't think. Okay, so
yes, I just wanted to touch on, as a matter of fact, just adding to what our friends have said, is about the waiting time. I wonder if any study has been made to find out the reason for the waiting time. Because what is happening is that if we consider a consultant to be the top doctor around, who, let's put it very vaguely, that who is more qualified to give his opinion in certain areas. But when we start, I wonder if there is, because I see that there should be some sort of a category. A patient goes, the preliminary investigations takes a bit of more time, and what happens is that the person goes directly to the consultant and he starts with all that procedure, and that perhaps takes a longer time. Waiting in the sense that what is happening is that a person goes directly to the consultant. He takes more time. Say, supposing my experience says it takes about 20 minutes to 25 minutes for a consultant to have a thorough investigation physically on a person, and then he starts prescribing or test, then he goes that side. What I thought that perhaps it would have been better as well that a person takes preliminary test at a lower level, a doctor or a nurse, for example, checking of the blood samples, and go to the doctor and he says that, all right, have other checks before it goes to the consultant. So what I feel is that waiting time to see a consultant is obviously more, because consultant takes the full responsibility of A to Z checks. That is something which is worth looking into, because for example, the cases of insurance, if you start looking, and the procedure is also so much, it's a lengthy procedure before a person really goes to a doctor and sees, filling up the form, identifying. These are the areas which needs to be looked into by the health authorities to make it more easier. Talking about absenteeism, I applaud really for example, I take the example of the Umri Medical Center, and I find that in Dar es Salaam, at least if I see Dar es Salaam, we have the best of consultants, one that you can find in Umri Medical Center. Now, seeing that consultant, there again the time factor comes, and it's a tedious job to see. But these consultants, I have no objections whatsoever. I must be very clear. You find that the services in the private sector are also being given by the same consultant. So the time there, when you talk of absent doctors, whether the absent doctor are they sick or have got a vaccine somewhere that they are not able to attend, or they are serving somebody else. He is doing a service, but if some sort of a balance could be brought, because obviously it's a matter of pride when a private hospital seeks advice from a government hospital or a doctor or a consultant. It's a matter of pride. So that is where you find that absenteeism is causing a lot of problems. I think these are the areas, and as we go along, because for example, I must say, applaud your good work, and indeed you're doing it. But I think more of these things when it goes through, and this is my first appearance in this August gathering, and I think I must congratulate for the work that you're doing. But instead of just finding And I am sure you must be doing, for example, absent doctors or insurance people, you must be taking it forward as to why this is happening. So if you find the answer as to why absenteeism, why long queues, if you look at the categories of doctors and nurses and the flow, rather the traffic of people going from entering the hospital to see the consultant, come out with a treatment. I think that traffic has
questions. We're still going to have a bit of a discussion, so don't give us all your opinions yet. Yeah? Okay, so maybe I can just say something in response, and then you can add where you see. So I think what you've raised here is quite interesting as a potential future question is what is the entire duration of time you spend in the hospital or health facility? So from the minute you walk in the door to the time you emerge with your medicines, and mostly it is with medicines. I mean, we checked this data, I think, in 2014, and it was, when I go to the doctor, it's about 94% of people come away being prescribed some kind of medication. So, I think, and as you say, to check each step would be really interesting. But in this case, it is very specifically not the time taken to be, registered. It's to be registered and see your first medical.
But in just a second, you see, my study, personal, I understand that the doctor, or shall we say any doctor, is given a target of about 25 to 30 patients a day. Now, how do we come to that? What is the result of those 25 patients coming out after the treatment? So that is the target given by the management to the doctor, that I expect, the management expects you to finish off 25 patients or 30 patients maximum.
Right, but sorry, so what you're talking about is a very Dar es Salaam specific context where you have this volume of patients. In rural facilities, you may not even in rural areas, so that's the kind of larger experience. But also to say on the same issue with kind of consulting in private hospitals, again, I think that is very specific to Dar. In kind of rural areas, what you're looking at is indeed the doctor is either not hired, because we do have a sort of broad shortage of medical personnel, or secondly they're actually absent from post, and it tends not to be that they're serving in, there aren't this plethora of private hospitals there for them to kind of go be serving in. So it's that idea that this is national rather than Dar es Salaam. I mean, we've always talked about in Dar es Salaam there's a lot of sort of differential factors, and it would be very interesting if we could do some of these surveys, compare, have a boosted sample for Dar es Salaam and for discussion. And again, please use whatever language is comfortable for you. I wanted to give you a couple of questions to guide you, but you're also free to obviously touch outside those topics. So I thought, one question is, what was most kind of interesting, surprising, insightful for you out of these findings that you've seen? Something which made you go, really? Okay, I see. So that was one of them. Another one is in terms of this issue behind the CHF, the Community Health Fund in particular, Improved Community Health Fund. Given that this is a sort of major strategy of the ministry to increase access to health services, and yet we're not seeing that rapid uptake, what could really be done in order to try and kind of move this a little bit faster so that people are getting that access? And then my third one is really about the fact that last year in particular we heard a lot of announcements about this issue of exempt groups, not they should not pay for treatment and care, but also the issue of PF3. Both, and even in our engagement with the police, they say, no, but we've announced it in a lot of places. Why is this still happening at health facilities? And so I wonder if, with all the expertise in the room, you guys can also help us muse on that issue. Why is there this disconnect? Okay, in terms of sort of free treatment, unless, we're thinking that people are charging and then pocketing the money, or what do we think is going on there? And with the PF3, to me, to be honest, it makes absolutely no sense. If you work in a health facility, your ultimate boss is the Minister of Health. She has come out and said, we don't need these PF3s before treatment, and yet more than half of people who go to get that kind of treatment are being forced to find these forms. And what could that be, and how do you bridge that gap and that disconnect? Because it doesn't seem to make a lot of sense to me. So those are the three questions I'll leave you with, but as I said, please feel free to kind of touch on other topics. I'll give you